Hey everyone, welcome to Medicine 3.0, your podcast that is the best information in AI, healthcare, and optimal living. In this podcast, I sat down with Shawn Stoll. He actually interviewed me for his podcast, but I thought I'd share it with you so that you could learn more about me, my philosophy, and the mission of Bionic Health. I hope you enjoy.
All right, welcome everybody. Today we have the amazing opportunity to talk to Dr. Pelo. He's got a really interesting background, beginning in emergency medicine, and since doing that, have the entrepreneurial spirit and started a few med tech companies. Currently with Bionic Health, doing a lot with AI and precision health. So we'll get a little bit into what that means. Other than that, welcome, Dr. Pelo.
Thank you, Shawn. I'm really excited to be here and just talk to you about healthcare and how we make it better.
Awesome. Yeah, we want to get into kind of why it's failing, where is it failing, and how we can, brainstorm together solutions. But I also want to hear about what you're doing with Bionic Health. But if you don't mind, kind of help us understand where you come from and tell us a little bit about your background in emergency medicine on forward.
Yeah, happy to. I love hearing people's stories because I think it tells you a lot about kind of what motivates them in life. And, growing up, I grew up in a small city in Utah, and Orem, Utah. And it was, I grew up in a very large family. So I was the last of 10 kids. And my mom kind of struggled with mental health issues. And I think like many people who go into medicine, it's because you see some sort of pain or you experience some sort of pain in your life and you think, oh, I want to be able to help people and fix these things. And as part of my journey through becoming a physician, I spent a couple of years on a church mission where I was in Argentina. And at the time, young 20-year-old kid and thinking, oh, I want to come back here and work in hospitals and save the world. That was kind of like what drove me to become a doctor. And so I went to my undergrad at Utah Valley University and then University of Virginia and applied to medical school. And when I get to medical school I think it's my first day, I'm going on this tour around the University of Utah Medical School campus, and the person giving me the tour, they said they'd done some like mission kind of work as a physician. And so I asked them what specialty they were going to go into. And they said, well, listen, if you want to do mission work, then you're going to be a surgeon, a primary care doctor, emergency medicine. And she said, I'm going to do emergency medicine because I think that's like the best. It covers like the broadest as far as going and doing international work. And so
it's like a catch-all. It covers all the bases.
Exactly. I mean, a lot about a little. It's kind of or a little about a lot. So you don't go super deep on any one specialty, but all the emergencies of every specialty. And so it's somewhat similar to primary care, just more focused on emergencies. And then the second piece is it's more procedural. So you learn how to do lots of minor and major surgeries. If you consider, opening somebody's chest up in the middle of a trauma bay, then that's pretty major. But there's a lot of minor surgeries, like when your kid splits their head open and you come in and we glue it back together, So I love that breadth of being able to, and I love, it's cool to be like on a plane and they say, is there a doctor on the plane? And you jump up and you're like there and you're the kind of doctor they want. They're like, oh yeah, that's exactly the kind of doctor we want. So emergency medicine for me has been kind of this cool place to learn how to take care of all these different things. And so it was a great fit for me to choose emergency medicine at that point in my life. But then a couple of interesting things happened. So one interesting thing, I start practicing medicine. I'm, graduate my residency. I'm in Lynchburg, Virginia. It's kind of this weird place because it's the middle of nowhere, but it's a really busy hospital. And we would see about 100,000 patients in our ER a year. And for context, there was one other hospital in the state of Virginia that was busier than us. And if you look at most emergency departments, that's like the top 10% of emergency departments as far as how busy they could be. And I was working for about 3 years. First year was just like magic. Like, people are nice to you when you're an attending doctor. When you're a resident, they're mean to you. Like, first year was like magic. I wasn't working nearly as much. I was actually making a living where I could support my family. But after a couple more years, I started getting a little disillusioned with feeling like I was there. There's a poem that John Denver reads where he talks about how there's an ambulance at the bottom of a cliff. And so people keep driving off the cliff and the ambulance is there to pick them up. But nobody ever thinks about putting a fence at the top of the cliff. Like, let's go back and fix the actual problem. And I felt like I was at the bottom of the cliff and I was catching diabetics out of control. I was catching people with cancer. I was catching people having their heart attack. And I was like, I want to go to the top of the cliff and maybe put a fence up and keep people from falling down the cliff. So that was kind of the first time that I started to think, I'm going to go do something in kind of preventative medicine. That was kind of the first time when I started to think that.
Awesome. So how long did you practice you're not practicing as an emergency physician anymore?
No. So I practiced for 10 years in the emergency department. And that was my first inkling that I wanted to do preventative medicine, but I didn't do it for almost another 10 years. And so in that 10 years, I got the entrepreneurial bug, like you talked about. I was on a break and I asked my partner, who seemed like the happiest guy in our group. And I was like, hey, Andy, you seem so happy. I'm getting burned out. How do you stay so happy? And he said, Jared, every day I have off, I just dread coming back to work. And I was like, that is the worst pep talk I've ever heard in my whole life. That was terrible. But what he said was, those who are happiest in medicine are either trying to fix it, like they're working to fix it, or they come up with a side gig and they're doing something else. And so I tried being a hospital administrator. I tried medical director of an ER for a year. And I learned within 3 or 4 months, I was like, oh, this is terrible. You take other people's problems, like not just taking care of my patients' problems, I'm taking care of other people's patients' problems. And so after a year, I started a company, and kind of the idea behind the company was called iScribes. It was doctors should be spending time focused on what's most important, the patient right in front of them, not focused on writing notes. So what if we recorded the doctor-patient conversation and then someday used AI to write notes for the doctors? When we started, it was kind of a virtual scribing service. So we had people working for us around the country who would scribe, and scribing is somewhat different than transcribing. They would kind of listen to the conversation and try to write a note like a doctor would write it. And then the doctor would review it, make edits, sign off on it. And we did that for 3 years. And we sold that to a company called Nuance Communications. They make a product called Dragon that most doctors will have heard about. And then we built that into a product called Dragon Ambient Experience, which is kind of like the top tier AI ambient listening technology out there today. And it's sold by Microsoft. And so that's how I got involved in technology and AI, was through, and I knew nothing other than, like, I was always kind of a tech geek. Like, I always liked to have the latest toy, the latest iPhone, Apple Watch. I'd switch between Android and Apple every year because I always wanted to stay on the cutting edge of which one. And so, yeah, it was really cool to start understanding engineering, start understanding AI, how electronic health records are actually built and why they don't function the way we want them to, health data, understanding interoperability, like all that stuff. Did that for 10 years. And at the end of that process, I'm working at Microsoft, and 2 things happened. One, I was playing with the most advanced AI models, things that weren't even available to the public yet, and imagining what we could automate for physicians. And then 2 was actually a family tragedy where my brother-in-law had a heart attack, and he died. And it was completely unexpected. Like, he was really healthy guy, mountain biker. He competed at like mountain bike competitions, and he was in southern Utah on a beautiful ride, and he died, and his friends tried to save him, but he was gone. And what I kind of felt was this, a little bit like, okay, Jared, it's time to start thinking about putting a fence at the top of the cliff. Like, I felt bad because, like, maybe I was too late for my brother-in-law, but at the same time, like, how many more people, if I go to work in this space, how many more people can I help? So that, you know, other people don't have to experience losing a loved one earlier than they need to. Everybody will die. I can't change that, but can we make it so that people live healthier, longer lives? So that's kind of when I decided to start Bionic Health with my co-founder, Robbie.
Awesome. Thanks for sharing that. Did you say he had a cardiac event?
Yeah, he had just had a massive heart attack. And, you know, it's crazy. We were at the beach. He would come into North Carolina and to go to the Outer Banks with me, usually once a year. We're at the beach, and he was telling me he has this mountain biking competition coming up. And he's like, I'm just a little more tired than usual. I'm just not recovering. And, like, of course, hindsight's 2020. So I'm like, oh, I should have known right then. But on his autopsy, they found that he had some silent heart attacks. And then he just had a major heart attack on that bike ride, and he was probably gone as soon as he tipped over. But yeah, and he died doing what he loves. I'm sure if he had the choice, he'd like to be around still. And I think everybody experiences this, right? Like, death is ubiquitous. Like, everybody will experience it one time or the other. Like, somebody that they love will die unexpectedly, or somebody you love will have dementia, or something that probably could have been prevented, advanced cancer, that if you'd been screening appropriately, you would have caught. Like, there are all these things that we can prevent: the heartache, the pain, the treatment, the cost, if we just do medicine in a much more intelligent way.
Yeah. I mean, I think those that work in healthcare, not that it's a numbing feeling, but they have a different perspective of ailments, illnesses, and even death. Not that any of those are welcomed, but
yeah,
working around it, you have a different perspective of it, just in general. Yeah, thanks for sharing that. Opening up a little bit about your passion. That's critical. You'd hope that every healthcare provider that you see, whether it's a nurse in the hospital, family doctor, emergency room physician, whoever, has that same passion. It's like, yeah, I don't want to I'm not here to just catch your symptoms and make them feel better and go on your way. That passion to prevent, right? To prevent.
Yeah.
And so in preparation for today, you know, I learned about precision medicine. Go ahead and define that for us and help us understand what precision medicine is.
Yeah, I think of it in several different categories. One is understanding risk appropriately. So I would say the way most of healthcare functions today is super reactive. So you wait until somebody is pre-diabetic or diabetic before you actually do something about it. Or, you know, we know that diet and exercise are going to be number one and number two things that are going to keep you healthy. But the doctor has 15 minutes with you once a year. And, you know,
if that, maybe not even 15 minutes,
right? Yeah. If you're young, you don't even have to be healthy. If you're young, you're going to get less time because you haven't developed those chronic illnesses yet. You're on your way, but you haven't developed them yet. And that's part of the risk analysis, because if you look at risk appropriately, you can start seeing chronic disease 30 years in the future. And if I can see chronic disease 30 years in the future, then I can make sure you never get that chronic disease. Now, you're eventually going to die, and you're most likely going to die of one of the things that kill most people. And those are heart attack, dementia, cancer, a fall, a trauma, something like that, you know, weakness. Like, you're going to age. But if if I'm looking 30 years in the future and I'm trying to keep you as healthy as possible, then I can keep you so much healthier for so much longer. And so it's actually an idea, I believe, is a Stanford professor in the 70s who came up with it, which was compression of morbidity. So instead of making it so there's this slow decline and then like 5 years of just terrible life at the end of your life, can we make it so that you more fall off a cliff? So your life is great, and then you compress all that morbidity, all that illness into as short a period of time as possible, and then you're gone. So the suffering for you and your family is less. And so that's kind of the idea behind precision medicine is let's understand risk appropriately and let's make you as healthy as possible so that we compress those sick years to days or weeks.
Yeah, well, I mean, you did the graph with your finger. Quality of life would be, up here.
Yep.
And you'd have that quality of life for a lot longer period of time later into your life. Yeah, that's awesome. So how do you do it?
Yeah, so you do it through several different ways. So I'll give a few examples. One is that medicine, and this is no fault of those practicing medicine, but they're usually practicing 10 to 15 years in the past. And that's because science takes a long time, and it's good that science takes a long time. You don't want science to move too fast. I mean, I think we saw during the pandemic that science moved as fast as it possibly could, but we learned, like going back retrospectively now, we can say, okay, we made some wrong assumptions here and there. We understood things incorrectly here and there. But that's the way science works. You make a hypothesis, you test the hypothesis, and you try to figure it out. And so, but that still means that things that we are very sure of that have been around for 10 years are still not being practiced. So I'll give you a few examples. So lipoprotein(a) is this little cholesterol tag that is 6 times more atherogenic, plaque causing than LDL cholesterol. And so if you have this and it's genetic and 20% of the population has it, then your risk of having a heart attack is double of just the general public. And it's super easy to screen for. It's actually American Heart Association says everybody with any family history of heart disease should screen for it. And so that's going to be like 50% of the population, but less than 1% of the population gets screened for it because we're practicing medicine kind of in the past. And so that's one way, appropriately screen for things. So like lipoprotein(a), making sure that cancer screenings are happening at the right intervals, maybe even using advanced cancer screenings that are newer technology, like the Gallery test that looks at cellular free DNA. It's called liquid biopsy that will look for cancer in your blood before it can even be visualized in MRI or a CT or anything like that. And so it's thinking about how do you catch cancer when it's in stage 1? Because if you do, it's curable. If you catch it in stage 3, it's not so curable. How do you catch cardiovascular disease before plaques are serious or rupturing? How do you capture dementia before you're starting to have Alzheimer's or small vessel disease? So it's understanding all of those things, screening for them appropriately, putting yourself on the right treatments with the help of a doctor kind of guiding you. And so it's really doing all of these things. And what's cool is we live at a time where this knowledge is becoming much more broadly known. So there's a best-selling book out right now. It's called Outlive by Peter Attia. And in that book, he kind of lays out what he calls medicine 3.0, which is instead of treating cohorts of people and recommendations for Shawn are just the same as they are for Jared, like, let's actually do this precisely to the person with an action plan that is precise for each of us. We have machine learning, we have AI, we can do these things at scale. We just have to build out the system. And it's hard to do in healthcare because healthcare is this behemoth, and it's running down the tracks, and it's really hard to take resources and divert them when we're barely handling in the US, we're barely handling what we can today, especially in primary care. And so how do you do this better? And so that's why Bionic Health, we sit completely outside of regular healthcare. Like we definitely send to specialists, but we don't accept regular insurance. We do it all completely outside because we wanted to make it as affordable as possible, which might sound crazy because we sit outside insurance, but insurance just makes everything way more expensive. So we sit outside of insurance and you deal directly with the doctor, and we make it very, very precise on how you receive care.
Yeah, I mean, those are the rails you got to go. You got to go outside of insurance, just because the year-over-year premium increase, just everything makes, like you said, everything so much more expensive. What's the patient or the customer experience with Bionic Health? So
the way it works today, and we're young, we've only been doing this about 18 months, but we're a healthcare technology company. I have 5 engineers that work here, and we're constantly building technology. And so the way it works today is somebody downloads our mobile application after they sign up. As soon as they download that, we start working on the back end. We pull in old labs. Pretty soon we're going to be hooked into the health information exchange. So we'll be able to pull full medical records for the person, and they'll own their own record in like this location that they can have access to. That will be so much easier to deal with than like a patient portal. It'll be like magic. People are like, this isn't healthcare. This feels like regular service. This feels like another line of service.
This information makes sense. I can access it. Yes,
exactly. They hook up their wearables. They set up some time with one of our advisors who are health coaches, and they take them through an onboarding call where they find out their family history. We actually spend time talking about nutrition and fitness and all the things that affect health, their sleep, their stress levels. They get a lab draw done where we check things like lipoprotein(a) and apolipoprotein B, things that your regular doctor doesn't have time or expertise to check. And then at the end of that, you meet with the doctor for an hour. So everything comes back, the doctor analyzes it. We use AI on the back end for clinical decision support to help us find things that maybe a doctor would miss. And then we present it back to you and we tell you, okay, this is your exact action plan. So we think you need to go deeper on brain health. And we think you need to go deeper on your physical performance and get a VO2 max test. So we take you through exactly what we think your plan for optimal health should be like. And then we put you on a monitoring program so that we test, we repeat, we test, we repeat, and we try to get you to a place where then it starts making sense. Your health trajectory is in a place where then maybe we don't have to talk to you as much, but you can talk to us anytime because we're just in the app just to chat away. You can chat with us anytime. So we try to make it super simple for the patient to access us, to access their coach kind of 24/7.
Wow, that's incredible. So with some of these services where they would need to go get tested, is that a network? I know you said you're young still. Is that something that you would refer them out to somewhere they would go? Let's say if it was a sleep study.
Yeah.
Is that you rent out a sleep room, or how does that work?
Yeah, so sleep is great because now you can do home testing. So we have a partner for home testing. So we'll order, it's called the Watch Pat 1, which is like, it's this watch thing. It sits on your finger. You get an electrode on your chest, and you do sleep apnea testing at home. And then we can prescribe CPAP to you. You can like get all that taken care of at home. We try to do as much as we can in the comfort of your home. So you can get labs drawn at home. You can get your sleep testing done at home. So we try to make that just kind of as seamless and easy as possible and bring in partners to fill the gaps that we don't have.
Yeah. And like you said, integrating health records and previous labs, AI just feeds off of data.
Yeah.
And that's what you're trying to collect, as much data about each individual as possible, right?
Mm-hmm.
I mean, it makes sense. Target does the same thing.
Yeah.
Not for our health,
Right.
more of our spending habits, right? Sign up for our card and you'll get 10%, but you'll also spend 20% more at our stores because we're going to advertise to you. No. But I mean, it's the same thing. They're just taking all this data, all of your personal data. That's what you're doing, essentially. Not to sell them something, not to get 20% out of it, but more back to your core, back to your purpose.
Yeah.
We know through the data what you need. You know what Shawn needs because I've given you all this information. I give you information I don't even know about. I don't know what my blood tests are. I haven't looked at my labs in a while, and even if I had, I wouldn't know what they meant. That's why I have my PCP. I go to him and he says, "Yeah, this is, keep the weight training, keep the cardio, go for a walk, whatever he suggests." That's why I have him. But it sounds like what you're talking about is 2 or 3 steps ahead of that, or 2 or 3 steps beyond what just my primary care can do for me.
Yeah, I mean, when I went through medical school, the amount of training I had on nutrition, like I got trained on how to give tube feeds. So if I wanted to feed somebody that was in the hospital that couldn't eat through their mouth or through their veins, I could feed them through their veins. And that's how I got trained on nutrition. I didn't get trained like, if you want to keep somebody as healthy as possible, this is how you need to eat. And the same with fitness. Like there was, but we know that like 80% of health really comes from, your fitness and your nutrition. And so we believe that you really have to integrate these things. And you see it, actually, it's interesting. So like Lifetime Fitness, Equinox Fitness, you see gyms coming up with like these like clinics inside their gyms because they understand that fitness and medicine should go together. And so for us, we're just trying to make it as approachable and attainable to as many people in the US as possible. And you mentioned like Target thinking about how to leverage their data. And like so many people are interested into getting into healthcare. Like, Walmart's tried, Amazon is trying, and it's partly to do healthcare, but it's partly to sell you other products. And really our goal is just how many people can we make healthy in this world? We want to track number of years extra lived. Like how many more healthy years have we added to the world? Our goal is 1 million. So our goal is to add 1 million more healthy years to the world. And so that's kind of what we track. It's not necessarily, how many more bottles of Tide do we sell?
Right. Well, and I didn't mean to cheapen what you were doing. I just, as you were saying that, it hit me something I had read previously about that. But
oh yeah.
Yeah. That's cool. 1 million years. Let's do it.
I know. Let's do it.
What else about Bionic Health? Did we cover all the bases there?
Yeah. I mean, I think we talked about like, what is kind of the basic flow of when somebody comes in. I think the long-term vision is really that everybody deserves the best healthcare in the world. Only a few people can really afford it today. And we want to make it more and more affordable for more people. Now, I think what's cool about what you guys are doing at CommonCare is you're helping people realize the dollars they're spending on healthcare, if they're spent differently, they can also get the best healthcare today. Because, I mean, like for me personally and my family, if it costs $24,000 a year to get insurance for me and my family, we only spend of that $24,000, $1,000 a year, but I have to put in $24,000. Like if I was able to just take my cash dollars and spend it on actual health care and then have my catastrophic insurance for something terrible, like I don't know why we treat health insurance so much different than car insurance. Like when I buy car insurance, I'm not buying the oil changes, the tire changes. Like I'm not buying everything. when I buy car insurance. But when I buy health insurance, I get all sorts of things I don't even want. Like, we're not going to reproduce anymore, my wife and I, but I'm still paying for like all the,
you got those benefits still.
all those benefits. Like, I don't want those. And so, I love what you guys are doing, because it actually makes it possible that people who maybe can't afford a concierge doctor or a private doctor or a direct pay doctor, through your network, they actually can find and use these services. So I think that's awesome.
Yeah. I mean, we're trying to identify wasted money, right? You're putting this money, you said 25,000. I don't have the numbers on me, but you're putting this money aside for insurance that you're not using, and evaluate risk you're probably not going to use.
Right.
Now, there are high consumers and high users who insurance, that makes sense. Why is health insurance not like traditional insurance, your home, your car? I don't know. It's a good thing that I don't have to go to, I don't know, the Toyota dealership to get my oil changed, because that's where I had my insurance through, right?
Yeah.
I can do it myself. I can take it to a friend who has the skills, or I can pay the extra money, take it to Toyota or whatever, and get it done that way. Yeah, it's a strange system, and so I think that kind of segues into where's the healthcare system now, and why is it in the situation it is? You mentioned you did health administration. You were director, medical director in emergency room. What, aside from not wanting to deal with others' problems and others' patients' problems, where was the disconnect with actually caring for people in the health system?
It's such a broken system, and it sounds cliche to say like it's a broken system because we've been saying it for so long, but it's so broken that until you get out of it, you don't really realize how broken it is. You do, because you feel it when you're in the system. You feel how broken it is, but once you get out of it and you can see it from the outside, you're like, wow, I do not understand how we ended up. And I don't believe that anybody with malintent like designed it to fail. I think we just gradually got here from all sorts of different decisions. And, the older doctors will point back and say, oh, the 70s and the 80s were the good old days. Those were the best days. And there is a little bit of truth in that physicians had more autonomy to do what they felt was right, and there was less oversight. I think it was probably less safe for patients back then. I think there have been changes for good and ill, but where I think it really hurts patients is when your physician and your nurse are more concerned about documenting, because if they don't document on you while you're there, they're going to be there 3 hours past work. And so they're concerned about documenting on you. They're concerned about these quality measures that get added every year. I'm getting licensed in multiple states, and my practice is completely virtual. I don't prescribe opiates, but I have to get training in opiates. I don't take care of kids, but I have to get training in child abuse. I have to get trained in human trafficking. So I have 11 hours of mandatory training that have nothing to do with me. And none of my practice. And that's just because as a system, we set up all these rules and we just keep adding to doctors' plates. Like, okay, you should be the ones that screen for human trafficking. Okay, you should be the ones that screen for this and that. And now you'll hear about social determinants of health, and doctors really do care. Like, they want to help people be healthier, but can they really find you a job or make sure that you're not experiencing racism or that shouldn't necessarily be on the doctor's plates, but we continue to put things like that on the doctor's plates. Now, we know healthcare outcomes are worse depending on social determinants of health. So I get it, but the solution is not keep piling things on the doctors, but that's part of the problem that I kind of recognized over the years is we just keep piling on. And so they have less time to actually take care of you, and they're spending way more time on all these other things.
Yeah. And for one reason or another, their plate's filling up. I mean, I've spoken to some primary physicians who were like, we get less than 7 minutes of FaceTime, face-to-face with a patient. In addition to that, some health systems are restricting, not questions. I mean, you can ask whatever you want, but if it's a different topic than the reason you came in, it's a separate visit. You need to come back, which isn't practicing health, or I guess even the definition of what medicine should be. If health is tied to it, then they need to take into effect the entirety. Right? We're talking precision health again. The entirety of that patient. I came in. I've got hip problems. 3 years ago, I broke my ankle. Well, that's all related. Your ankle probably didn't heal appropriately. You didn't get the physical therapy you needed to do, and now there's a misalignment. But you came in for hips, so we're going to work on your hips, and here's the ortho to go see, or here's a physical therapist to go see. I've got another patient. Not to fault the physicians at all. It's a story after story I've heard of. Not the physicians don't have enough time to treat or to actually understand the patient's concerns, which is something I don't have experience with. I'm more of a patient, right? I go in and I'm like, okay, I've got my list of questions, and maybe I've even written them down. And it's the whirlwind. The white coat comes in, the stethoscope comes and listens, and they say the 4 or 5 things they have to say, and my questions completely fleet out of my mind. Do you have anything? You have any questions? No, I'm healthy. I'm good. Okay, thanks.
Yeah.
Oh yeah, no, I did have this question, but they're already gone. Yeah. And it's everything I just said is not news to you. You understand it as well. It's just where do we go from now? I talked to a lot of DPC. They solved that problem in one way or another. The time with the patients.
Well, it's interesting if you ask a primary care doctor at like a big institution how many patients they take care of, and it's usually going to be on the order of 11 to 1,200 active patients, and then maybe another 1,000 or 2 of less active patients. And just think about how many hours a year somebody can work, and how many patients, like how much time can you give per patient? And now add in there, like some of them are really ill, complex people, and the time that you can spend with them is so low. And so it's just a really interesting space that I don't think we can solve unless we figure out how to solve some of the administrative work that we're putting on doctors, unless we can help them with clinical decisions, help make it faster, easier. And then I think, we have to continue to figure out how do we leverage our advanced practice providers? How do we build out all these tools to do more for our patients? And you mentioned, being able to ask all your questions. And one of the things that you'll hear doctors complain about today is now they have an email that their patients can email them at. And at first, the institutions were like trying to incentivize patients to email. And now institutions are charging patients to email. So if you want to send your doctor a message, it might be $10 or $15. And which to me is crazy. Like, I want you to be as healthy as possible. I want you to ask me all your questions, but we can only get to that kind of volume where I can take, 10 questions a year from each person if I have automation, if I have technology, if I have the ability to answer quickly. So I think we have to solve this problem with better systems, better technology, better care.
So I like what you're saying. but I can hear early in my career, I worked in an endoscopy lab as a technician helping with the endoscopy. And we had a new EMR come out, and a few of the physicians just didn't enjoy the experience. There was a big learning curve for some of them. One would say, you're adding clicks. Every click is, 10 minutes of my life or something. I don't know exactly what he said, but alluding to the more technology advances, the more that regulations are using this technology, slowing down my practice, slowing down what I do and what I do best, and it's hindering my performance. You're on the tech side of things, and I feel like I'm more in your boat than my physician friend. That we can leverage technology to actually create more time or free up some more time. How do you combat that? I assume you've faced that with physician peers, that wall of, no, I don't want to learn a new tool, a new app, a new this.
Yeah.
How do you cross that bridge, or how do you address that challenge?
So a few interesting things around this. Like, one is, you have to remember how electronic medical records got forced onto medicine. It had been growing. Epic and Cerner had been kind of naturally growing. And then the High Trust Act, the Affordable Care Act, meaningful use, like, everybody had to adopt an EHR to receive certain dollars. And so they did that, and they weren't ready. The electronic health records were not ready. And so you ended up with technology that wasn't great. And it didn't change for a long, long time, because it was this huge growth. And then it took a long time for electronic health records to get back to innovating and building new things. And so that was one of my biggest problems with my last company. Was I'd go say, I'm going to save you 2 hours a day of documentation. And they'd say, that's what I heard when they were selling me the EHR. And so, yeah, it was kind of magic to actually do it and have them save 2 hours a day. And they'd be like, oh, this is amazing. This is the best thing ever. I had so many people say, I'm going to practice medicine 10 more years because of this. And so I think that's part of it. You have to really build great technology. But then the second thing is, you have to realize that with automation and with technology, usually it does mean more work. Like, if you look at our homes, we have dishwashers now, we have washing machines, we have like all these machines that do work that we used to have to do manually. And it used to be that most people would have one person in the home stayed at home so that they could do that work, because it was like a full-time job. And now many families, like, both people are working because they have that extra bandwidth. And so it's not like automating those tasks made it so that somebody just sat around. It just kind of increased the bandwidth of the household to do work. And so as we increase the bandwidth of doctors, my vision is not that doctors will take care of less and less patients. The vision is doctors will take care of more and more patients. And I think for doctors, that sounds terrible. So our doctors today see anywhere from 300 to 400 members. So not a very big census compared to the 1,100 or 1,200. But there will be a day when we have enough automation that our doctors will be taking care of 1,100 or 1,200. And my doctors today probably think that sounds terrible, but they assume that we're going to have the same amount of automation that we have right now. And so the trick is, like, how do you make it so the work is still enjoyable, that human to human contact is still happening, that doctor-patient relationship, it's meaningful, it's good. And so those are things that we have to keep top of mind as we, like, innovate and build these tools.
So great. I mean, yeah, I like the analogy of chores around the house. The dishes and the laundry can all be done while you're mowing the lawn.
Yeah.
Yeah, they can be automated. So increasing bandwidth is critical. You also touched on the relationship, patient-provider relationship. And I guess in your eyes, why is that important to build that relationship, and maybe how is that best done?
I mean, relationships usually can't be shortcut. Like,
Okay.
you can kind of, there are very traumatic periods of time where relationships can happen very fast. So I'll give you some examples. Like in the ER, I could grow very close with somebody over a matter of a couple hours while I'm taking care of their sick loved one. Like I'm trying to save their life. They see me working hard. We talk for 5 minutes here and there, and they trust me completely. But since that isn't the case in the primary care setting, usually it's going to take more time. And I don't know yet how to necessarily shortcut that other than kind of multiple touches both directions. So one way we do this is through asynchronous video. So, we'll send videos to our members where we're talking to them, and they'll send messages back to us so that we can get to know each other in a more efficient manner than like blocking out an hour for us to like sit together and talk together. And so I think it's figuring out like, what are the different tools we can use to build a relationship where you trust me, I trust you, you know that I have your best interest at heart, and you trust the decisions I'm making, because you know that when I make health decisions for you, I'm thinking just like I would, like, what if this was my brother? What if this was my uncle, my father? What would I recommend? And that's the kind of trust you want with your caregiver, is you want them to think of you kind of in that intimate way.
Yeah. You said earlier sometime about knowledge or information, medical treatments. We're in the information era or information stage of technology where nearly anything is accessible on our phones or just a quick search away. And so with that, knowledge and obtaining of knowledge is not proprietary, right? Doctors don't own the market of knowing everything about health, and that's a good thing, right? Challenge. A patient should be able to challenge or question or second opinion or this or that, and I think that's a good thing to enable the patients to really own their health. Obtaining knowledge from the correct sources may not be always the easiest to do, but I think in the information technology space that we're in, I think it's becoming easier. What are your thoughts on knowledge not being proprietary to? I'm talking specifically health knowledge, proprietary to physicians, as part of that building that relationship.
Yeah, I think I love having my patients question. I love having my patients send me articles, and because it shows me they care. It shows me that they're thinking, and that they're engaged in their own health and they want to be healthy. And like I talked about science changing, it can be a little disconcerting for somebody if, for years and years, they were on a medication and then they hear like, okay, this medication is no longer considered safe. Or, this used to be how we'd screen for something and now we screen like this. Or this used to be a treatment that we no longer use. And so it's important that people understand the process of science. And, science isn't just a straight line up. It's kind of, ups and downs. We continue to make progress, amazing progress. But yeah, I love for my patients to dig in, care about their own health, listen to podcasts, like all of those things. And then it is on the doctor to stay educated and to kind of stay up to date as they can anyways.
Yeah. Awesome. Kind of want to kind of conclude the conversation with talking about the current healthcare. We did already address some of these things.
Yeah.
AI is big for you. You're learning a lot in this space, and you're on the side where it's how can AI help? Are there any examples where it can be kind of detrimental or where it could hinder healthcare in our current situation?
Absolutely. So to me, AI, it's just a tool. And it's like fire. You can use fire to cook your meat, your dinner, or it could burn down your house. And so you need to use it in a controlled way, and in a safe way. So the way that I think about AI is where it's at today. It is not safe to trust AI and in just any willy-nilly way. You need an expert who understands, and there's different kinds of AI. And most people, when I say AI today, they're going to think ChatGPT or something like that. But there are all different types of AI that are working in different systems around us. And there are a couple different trade-offs to always understand with AI. There is speed and accuracy and data amount. And so the larger amount of data you have, the better your AI is going to be. If you want really high accuracy, you're not going to have very high speed to start, because you're going to need multiple checks and you're going to need multiple systems. And it's a little bit of why we only use our AI in preventative health, because the decisions we make, it's okay if they take a little bit of time. We're not in the ER. We're not in the intensive care unit. Like, I don't have to make life and death decisions second to second. An AI system in that field would have to be very, very narrow and very, very niche. And that's how AI systems are used in those areas today. And we're building this kind of broad overlay of AI to help doctors communicate, to help doctors make decisions. And so we're building it in this like very safe environment. So that's one way to think about it. The other way to think about it is, where do you want your health data to be safe and shared and things like that? And so, like, never upload your data to like a general website. Don't upload your data to ChatGPT. Really only use like HIPAA compliant, which if you're questioning if something is HIPAA compliant or not, it's probably not. Like,
yeah.
If you have that question, don't do it.
Yeah.
So yeah, I think there's lots of care needs to be taken around AI. You got to be safe with it.
Awesome. Thank you for sitting down with me today. Enjoyed the conversation. Thank you for opening up and telling me a little bit about your life and your story. I had a wonderful conversation. Thank you so much.
Thanks, Shawn. This was a lot of fun.